Hello, and welcome to the Dyscrasias Clinical Education Oncology podcast. I'm your host, Ryan Topping. Today's episode features Dr. Thanos Dimopoulos from the University of Athens and Alexandra Hospital in Athens, Greece, and Dr. María-Victoria Mateos from the University Hospital of Salamanca in Salamanca, Spain, as they discuss the use of CELMoD agents to manage multiple myeloma, including the recent FDA approval of iberdomide, mechanism of action and differentiation of CELMoDs from IMiDs, and current data and potential treatment settings. This episode is part of a larger educational program titled Novel Approaches in Relapsed Refractory Multiple Myeloma, Expert Perspectives on Emerging Data and Ongoing Trials. For more information, along with a link to the larger education program, please visit the show notes for this episode. Now, let's get started and hear what our experts have to say about this important topic.
Hello to everyone, and welcome to this podcast in which we will have the opportunity to discuss about CELMoD's agents for multiple myeloma. My name is María-Victoria Mateos, and I work as hematologist at the University Hospital of Salamanca in Spain, and Professor Dimopoulos will join me this podcast today. And Thanos, do you want to introduce yourself?
Hello, thank you for the opportunity to participate in this podcast. I'm Thanos Dimopoulos. I work at the Department of Clinical Therapeutics, University of Athens in Athens, Greece. And I just want to ask Dr. Mateos, since we have so many agents for the treatment of myeloma, and we have seen that the outcome of patients has improved dramatically, is there a need to have a new class of agents?
Thank you very much, Thanos. And I think that your question is very appropriate because when we plan what are the therapeutic needs in multiple myeloma, maybe today we don't need more active drugs, but what we have to plan, and for me, this is the most important medical need we have in myeloma, is to deliver the right therapy to the right patient at the right time, because the evolution of the main objectives we have today for multiple myeloma is to achieve disease control, but to reach deep responses, sustain at the minimal residual disease negativity, treatment-free remissions, and potential cure. And it's true that the classical proteasome inhibitors, immunomodulatory drugs, and anti-CD38 monoclonal antibodies are basically taking part of the first line of therapy. The majority of the patients are going to be triple class exposed, and it's true that not all patients are going to be refractory to all these compounds at the moment of the first relapse. But definitely, although the progression-free survival is becoming longer and longer after the first line of therapy, we have at the end of the day patients at the moment of the first relapse. And we have to deal with these patients, and we have to incorporate the novel T-cell redirecting therapies that basically these novel therapeutic approaches clearly change the treatment landscape for patients with multiple myeloma. But the landscape is quite crowded in terms of T-cell redirecting therapies, and CAR-Ts, bispecific monoclonal antibodies, do utilize the T-cells. So the importance of the immune system makes sense in order to incorporate, why not, novel compounds. And we are going to discuss it today about CELMoDs. And because of their mechanism of action, we know that they are going to enhance the immune system. And this is going to be crucial in order to try to offer excellent outcomes for myeloma patients, maybe after the first 2 or 3 lines of therapy. So this is what I consider, and in the future, majority of the patients will receive maybe no more than 2-3 lines of therapy. And based on this, of course, we will continue having unmet needs in patients with high risk and ultra high risk disease. We have to try to improve the access of patients to all these novel therapeutic approaches. We have to try to reduce treatment burden. So myeloma patients are going to arrive at the relapse setting more elderly, sometimes a frail population, and we have to try to deliver safer and very effective combinations also to these patients. So I think that these are basically what I consider the therapeutic needs in multiple myeloma. And if we focus on the CELMoDs, Professor Dimopoulos, so what are CELMoD agents, and what is the mechanism of action, and how these CELMoD agents differentiate from the classical immunomodulatory drugs that we've been using for the last 20 or 25 years in myeloma?
Yes, you're right, Marie-V. I agree with you that despite the progress that we have made, we still need agents that have a different mechanism of action. CELMoDs are not really IMiDs. Iberdomide and mezigdomide are the two CELMoDs that are in clinical development. They bind to cereblon within the CRL4 ligase complex. And this binding is much more effective than the one that we're seeing with IMiDs. They enhance recruitment and ubiquitination of the transcription factor Icaros and Deolos, and these polyubiquitinated substrate are subsequently degraded by the proteasome. This results in suppression of the IR4 MYC-dependent survival pathways, and they promote downstream immunomodulatory effects, including augmenting T cell activation, NK cell expansion, and myeloma activity. And as you pointed out, T cell exhaustion is a key factor, not only because it is associated with increased risk of severe infection, but also because it is considered to represent a mechanism of resistance to T cell redirecting therapies. And there are data, both in vitro and in vivo, which indicate that mezigdomide, for example, stimulates T cell activation and reduces T cell exhaustion markers, both clinically and preclinically.
Yes, thank you very much, Thanos. And well, the most common CELMoD agents we have today are iberdomide, mezigdomide. So do you have any feedback about other CELMoDs like femsidomide or another ones that definitely they are different because they are only in clinical research?
Yes, you're right. Especially, we are very excited because very recently, actually a couple of days ago, we had the approval by FDA of the combination of iberdomide with daratumumab and dexamethasone based on the Excalibur RRMM study. How do you see this approval affecting the treatment of multiple myeloma, Marie-V?
So I think that this is great because, well, the information we have so far about these new CELMoDs in patients with multiple myeloma is good. And it's true that we had to wait until Excalibur RRMM for the approval of iberdomide, the first CELMoD so far approved in relapsed refractory myeloma. In combination with the daratumumab and dexamethasone, we know that mezigdomide will be maybe also approved in combination with carfilzomib and dexamethasone based on the SUCCESSOR-2 study that it was presented at ASCO and as well as EHA this year in June. But well, if we go back, I think that we have phase 1 or 2 clinical studies in which we had the opportunity to see how iberdomide, plasdomide, plus dexamethasone were indeed effective in the unmet medical need population we had some years ago, the triple class exposed and the triple class refractory population. And I would like just to remark some important concepts because we've seen how mezigdomide and dexamethasone was also evaluated in subgroup of patients previously exposed to BCMA targeting in patients previously refractory to lenalidomide and pomalidomide. What it is important. Also, the extramedullary disease subgroup of patients, we know that they are an unmet medical need population, and mezigdomide and dexamethasone in the phase 2 clinical study showed to be also effective in this population. And now we have, I think, that excellent news because we have, as you pointed out, iberdomide daratumumab trial so far approved by FDA. But there is another important information. This is the first phase 3 clinical study that has been approved based on the new endpoint, minimal residual disease and complete response. And we know that iberdomide Daradex basically duplicated the MRD negativity rate, as we've seen in the press release, and the PFS will be coming, but definitely this is the first time the authorities are considering, based on the excellent data reported in the Successor 2 clinical study, we will have the opportunity to have these two new combinations based on CELMoDs based combination in earlier lines of therapy. That from my point of view, this is the excellent place in order to use the CELMoDs today, although we have also clinical studies and some data about iberdomide in combination with bortezomib, in combination with daratumumab as part of the first line of therapy. And you know that there is indeed a phase 3 clinical study ongoing evaluating iberdomide as maintenance therapy after autologous stem cell transplantation.
I think this is a great point that since we have now the approval of an iberdomide-based combination, we are looking forward to two large randomized studies that are evaluating iberdomide head-to-head comparison with lenalidomide, maybe replacing lenalidomide in the future in the frontline setting, and also an important study comparing iberdomide and lenalidomide as maintenance. So one may envision that in the future, iberdomide will be used in the front line, in the consolidation, and as maintenance, whereas mezigdomide may have a major role later in the course of the disease, probably as a bridging therapy between T-cell directing therapies. However, there are some concerns regarding the safety of these drugs, which is the major side effect of iberdomide and mezigdomide based on your evaluation of the data that are available.
Yeah, and do you want to comment something about the key safety data of this?
I think a non-target effect is the neutropenia that we see frequently with mezigdomide, and in Successor 2 study, we had a significantly higher rate of neutropenia. However, this neutropenia is predictable, it is short-lived, it is not associated with a higher risk of infection, and one practical approach that we used in this study and in the use of mezigdomide outside the clinical trials is as soon as we see grade 3 or 4 neutropenia, we continue the treatment by using G-CSF on a regular basis. In my mind, this is the major complication of the drug. I have been also pleasantly surprised to see in the randomized maintenance study that the use of iberdomide as maintenance is associated with a much lower frequency of diarrhea, which is a major obstacle in the long-term use of lenalidomide. I don't know what is your experience with these two agents as far as safety is concerned.
Yeah, exactly what you said. I think that the management is quite easy, but we have to take care of neutropenia because it is the most frequent adverse event, and it is grade 3-4 in majority of the patients. So we should pay attention in order to be very proactive with the use of G-CSF. And I would say that the incidence of grade 3-4 neutropenia is even more pronounced with mezigdomide than iberdomide. And indeed, I have now several patients included in clinical trials with novel combinations based on mezigdomide plus novel compounds, and we have to plan the primary prophylaxis with the G-CSF. It's true that with this approach, neutrophils recovered and patients are able to initiate every cycle, and this is important. The second important consideration is what you said, that in spite of the high frequency of severe infections, and it is extremely important to see how some other adverse events like asthenia, fatigue, diarrhea are not present with these new CELMoDs because of the conformation, because of the structure of these CELMoDs is different in comparison with lenalidomide and pomalidomide, and it's true that in the clinical practice we don't see this non-hematological adverse event. But Thanos, correct me, we have to continue using the thromboprophylaxis with these new CELMoDs, right?
Yes, the rate, of course, of deep vein thrombosis in successor 2 was quite low. However, it is something that we have to keep in mind. In the majority of our patients, I believe that we can use low-dose aspirin, but there are patients that may need heparin or DOAC. Mariví, let me ask you, when the combination of mezigdomide with calcifimab dexamethasone will be approved, and hopefully this will happen in the next few months, where do you see this combination being used today?
Yeah,
in what
so
type of clinical setting?
well, I have to say that for me, successor 2, and especially mezigdomide, carfilzomib, and dexamethasone was evaluated in a truly unmet needed population after just 1 or 2 prior lines of therapy, because majority of the patients were not only refractory to lenalidomide, but also refractory to anti-CD38 monoclonal antibodies. And when we evaluated the efficacy of the control arm in this study, carfilzomib and dexamethasone, median PFS 8 months, and we've seen how mezigdomide plus KD resulted in a median PFS of 1.5 years. I think that in this population, this is the ideal place to use. But for me, it's true that the key point is how to deal with mezig-KD, maybe in the context of gene therapy.
Absolutely.
And it's true that the only data we have in a similar population to the population included in successor 2 is teclistamab in the Majestic-9 clinical study. And in Majestic-9, the PFS has not been reached yet, but I can't envision a very, very different progression-free survival. So I think that maybe we don't have to select one or another. Both are available, and even it is possible to sequence one after the other. And I think that this is one of the main advantages of the CELMoDs, because they are going to enhance the immune system. They don't need, in principle, the T cells, as this is the case for bispecifics. And I think that mezigdomide, KD, but the same is applicable to iberdomide, complement very well the treatment landscape in earlier lines of therapy, complemented with either CAR-Ts, and you pointed out before about the role of bridging therapy, but also in order to sequence this T-cell redirected therapy.
No, I agree with you, and I would like also to make the point that although bispecifics are very active, they are associated with severe hypogammaglobulinemia. They are associated with sometimes severe infections that can be unpredictable. And there are several practicing physicians, especially in smaller centers, in community setups, that are skeptical about this potential complication, whereas the combinations that include iberdomide and mezigdomide can be given in all clinical settings. The main issue is neutropenia. Hematologists know how to deal with neutropenia. The rate of hypogammaglobulinemia in the successor 2 study was very low, was about 10%. The need for immunoglobulin administration was 20%, 25%, whereas we know that with specifics, essentially all patients need to take immunoglobulin. So there is the activity, but also there is the issue of safety and the ease of administration. These regimens, these oral drugs, can be given easily to outpatient settings. in all type of practices, not only in academic centers, but also in smaller community clinical practices. And I think this is an important issue sometimes to select therapies.
Yes, of course. And even just to add that we are evaluating different new combinations based on the bispecific monoclonal antibodies plus the CELMoDs. And we have some data based on the combination of iberdomide plus elranatamab, the BCMA bispecific monoclonal antibody. And the data are preliminary and were presented at ASH 2025. But the overall response rate for this majority of the patients triple class exposed and triple class refractory was over 90%. So I think that there is another possibility for combining CELMoDs with the T-cell redirecting therapy, like bispecific monoclonal antibodies. And as we've previously discussed, I think that the CELMoDs are going to be very valid in order to sequence CAR T-cell therapy bispecific monoclonal antibodies, and why not to incorporate also belantamab mafodotin, that it will be another potential combinations, belantamab in combination with either iberdomide.
Absolutely. And we made the point, but it's important to repeat it, that mezigdomide-based combinations, they seem to have activity in plasmacytomas, paraskeletal extramedullary plasmacytomas. There are some data regarding activity in CNS involvement of the myeloma, of the combination. So these are important issues, especially when we're dealing with patients that have advanced refractory disease.
Yes, of course. I don't know if you visualize any potential barrier to the near future CELMoDs agents integration into the treatment landscape for patients with multiple myeloma.
Yeah, I think, as you said at the beginning, we have many active combinations, and it is important to find a way to sequence them in the best appropriate manner, so that a given patient can take advantage of all these new therapies. So in my mind, I see in the future iberdomide replacing lenalidomide in the quadruples or in the triplets, and also in the maintenance, single agent in the future in combination with daratumumab or anti-CD38. There is a Spanish trial which is evaluating this approach, a very important study. And mezigdomide probably playing the role of pomalidomide in the more advanced setting as a bridging therapy, second line when there is some skepticism about the potential use of a bispecific, history of infection, distance from a major hospital center, as a bridging therapy in combination. As you said, there are studies with both iberdomide and mezigdomide in combination with bispecifics to enhance their activity, to reduce T-cell exhaustion, which is a factor of resistance to bispecifics. So I believe that these agents, as they are becoming available through the approval of several studies, they will provide an additional way to prolong the life of our patients with myeloma and to have the prospect of cure in more patients than we have today.
Yes, I completely agree. And if you allow me just to add something in which maybe we have to educate to the medical doctors, because some consider if my patient is already pomalidomide refractory, why would I use another cerebron targeting agent? And I think that the biological and clinical distinction, more potent and rapid Icarus and Aiolos degradation and activity despite IMiD refractoriness needs to be clearly understood, and we should emphasize this amongst the clinicians, because these CELMoDs are not better IMiDs, are different agents, and you explained very well their mechanism of action, and they are more potent. And
also we have clinical data from Successor 2 where up to 1/3 of patients were pomalidomide resistant.
Pomalidomide refractory,
And,
exactly.
they had a significant benefit from the combination of calcifomib with mezigdomide and dexamethasone.
Exactly. So thank you very much, Thanos, and it has been for me to have these
And we're looking
CELMoDs.
forward, to see data from other studies, as you mentioned, from Excalibur RRMM, the PFS data, and also the overall survival data from Successor 2. And by the end of the year, we will have the data from Successor 1. And hopefully this is a journey that is starting for CELMoDs, and it will be a very positive one.
Absolutely. Thank you very much.
Thank you, Dr. Dimopoulos and Dr. Mateos, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Novel Approaches in Relapsed Refractory Multiple Myeloma, Expert Perspectives on Emerging Data and Ongoing Trials, please click the link in the show notes. And be sure to check back regularly for more episodes on important DSERA clinical education oncology podcast topics.